Good morning, good afternoon, good evening, everybody. Thank you for joining us for this session. We are very excited to be here to talk a little bit about gender blind, gender to transformative, addressing gender equity and intersectionality in human resources for health research. My name is Dr. Mwenyeka Sunday, and I am joined with a great team, which I'll introduce to you in just a few minutes as the speakers go ahead. But in order to set the scene for the conversation this afternoon where I am, I'm going to just share with you a short presentation, and that will really talk a little bit more about what we're going to be discussing and just set the scene for the conversation. So why are we having this discussion today? Well, the answer to that is simple. Women make up 70% of the 200 million workers who contribute to the health and social workforce. Women deliver health and social care to around 5 billion people worldwide, and women in the health and social sector contribute $3 trillion annually, half in the form of unpaid care work. With a predicted shortfall of almost 18 million health workers by 2030, investing in the health and social workforce is investing in women's economic participation and empowerment. Underinvestment in the female health workforce undermines the prospects of achieving the health-related sustainable development goals. And to talk a little bit more about the Sustainable Development Goals, addressing gender biases and inequalities in the health workforce is essential, not just for achieving the SDG 5, which is gender equality, but also SDG 3, SDG 4, SDG 1, SDG 8, SDG 10, SDG 16, and 17. The Global Strategy on Human Resources for Health Workforce 2030 was published by the WHO in 2016. And the strategy aims towards attaining the SDGs and universal health coverage by ensuring equitable access to health workers. It calls for alignment of gender, employment, education, and health with national human resources for health development and health system strengthening strategies. The strategy also emphasizes that the health and social sector is uniquely positioned to offer substantial and tangible opportunities for decent work, gender equity, and greater women's labor participation. Also working with the Health for 5-Year Action Plan, with the WHO and ILO and OECD, supports the implementation of the High-Level Commission with 10 recommendations. And two of these key recommendations are the development of gender transformative global policy guidance and support to build implementation capacity to overcome gender biases, inequalities in the health and education labor markets. In 2018, the Gender Equity Hub identified and reviewed over 170 studies in a literature review of gender and equity in the global health workforce. And the key messages that came out of the report that was published in 2019, titled Global Health Delivered by Women, Led by Men, is that number one, women deliver global health and men lead it. Secondly, workplace gender biases and discrimination and inequities are systemic. Women in global health are underpaid and often unpaid. Number four, workplace violence and sexual harassment in the health and social sector are widespread and often hidden. And number five, occupational segregation by gender is deep and universal. So why does this matter? And I think the best way of summarizing this is by bringing forward what we call the triple gender dividend. Adopting gender transformative policies and addressing gender inequalities and investing in decent health will offer wider social and economic multiplier. To number one, a health dividend, millions of jobs needed to meet growing healthcare demands and demographic changes will be filled. Secondly, the gender equality dividend, women will gain income, education, and autonomy, leading to improvements in education, health, and other aspects of development. And thirdly, the development dividend. New jobs will be created, fueling economic growth. Some of the key policy areas that were prioritized in the report were, number one, addressing occupational segregation, eradicating the gender discriminatory practices that cause occupational segregation, with women typically clustered in lower status jobs with less pay. Also addressing decent work, ensuring that all health workers are given fair and equal pay, as well as protected from discrimination, bias, sexual harassment within the healthcare workforce. Addressing the gender pay gap, guaranteeing that men and women receive the same pay for health and social work of equal value, and also addressing leadership and governance, eliminating the barriers that impede women from achieving leadership positions within global health. So let's talk a little bit more about occupational segregation. Female majority professions are typically given lower social value, status, and pay. This is often driven by gender norms and stereotypes of jobs culturally labeled men or women's work. Gender discrimination constrains women's leadership and seniority, and gender stereotypes also constrains men's career choices, for example, in nursing. Here you see a very typical statistics on the level of occupational segregation in the US currently. And as we know, there are very few men that go into the nursing profession as well. With regards to unpaid care work, unpaid and informal work makes up nearly half of women's contribution to the global health sector. This directly correlates with occupational downgrading, with women remaining segregated into part-time or vulnerable working conditions. Talking a little bit more about decent work, a large number of women in the health workforce face bias, discrimination, and sexual harassment. Frontline female health workers, often in conflict, emergencies, and remote areas, do face injury, violence, and unfortunately, death. Female health workers face widespread sexual harassment from colleagues, patients, and community members alike. Often, women do not report sexual harassment due to fear of retaliation and potential impact on their careers. When it comes to sexual harassment laws, 59 countries, it was found, do not have laws prohibiting sexual harassment in the workplace, and 100 countries do not have civil remedies for sexual harassment in the workplace. 110 countries do not have criminal penalties for sexual harassment as well. Talking a little bit more about the gender pay gap, globally, women earn 70 cents for every dollar earned by men, a gap that is estimated to take 70 years to close. Driven by occupational segregation again, with women in low status roles, mostly unexplained by observable factors, much of women's work in health is unpaid and excluded in the gender pay gap data. This leads to a lifetime of economic disadvantage for women. Closing the gender pay gap is therefore essential to achieving the Sustainable Development Goals. On leadership, it's been found that women, even though they make up 70% of the global health workforce, they only hold about 25% of senior roles. Global health is weakened by the loss of female talent, ideas, and knowledge. And this goes across the board in positions of healthcare CEOs, ministers of health, World Health Assembly heads of delegations, etc. So something that we found in the research that still there are some gaps, and it's important for us that we change the narrative. And the major gaps found in the research is that most of the data examined was firstly from the global north. Data and research from lower and middle income countries on gender and equity is definitely missing. Implementation research on impact policy change or gender transformative approaches of different cultural settings needs to be considered. And we also found limited methodological approaches, with very few adopting intersectionality into these research approaches. With regards to report recommendations, We recommend to use the report findings and the analysis of best practices from within and beyond the health and social sector to inform gender transformative policy and action. It is also recommended to develop advocacy and policy toolkits to target key stakeholders to integrate gender transformative health and social workforce policies into their national workforce plans. And finally, it is recommended to convene stakeholders at the national level to design and evaluate gender transformative health workforce policy interventions with the aims of supporting implementation and measurement of context and evidence-based policy options. It is important that we value and invest in women enabling environments, engaging women and all genders as allies and female representation in decision making. I've reached the end of my presentation, and at this stage, I'm going to hand over to Dr. Rosemary Morgan to talk a little bit more on the topic as well. Rosemary, I'm handing over to you.
Great, thank you so much, Moria. I will share my screen and welcome everyone here today. I'm delighted to be here today. I'm Rosemary Morgan. I'm based at Johns Hopkins Bloomberg School of Public Health. And before we get to our excellent panelists today who are going to be talking about how they themselves have conducted research using a gender lens in relation to human resources for health to address those gaps that Moria pointed out in her presentation. So I am going to also just set the stage a little bit because, you know, we can't address a problem if we don't have data and findings on how to do it. We need evidence, we need data. But how do we do that? How do we incorporate a gender equity and intersectionality into human resources for health research? First, I wanted to start off with a definition of gender analysis, so to make sure that we're all on the same page. This comes from the paper that myself and my colleagues have published on how to do gender analysis and health systems research. And in the paper, we define it as the process of analyzing how gender power relations affects people's lives, creates differences in people's needs and experiences, and then how policies, services, and programs can help address these differences. Because it's not enough just to collect the data and evidence, we need to now also do something about it. So what are some of the gender analysis activities within the research and intervention process? We often use this model here that uses the World Health Organization Gender Assessment Scale, which looks at it has 5 stages of research, and you can see that on the right-hand side. So at the bottom, we have gender unequal research. This is research or interventions that perpetuate gender inequality by reinforcing unbalanced norms, roles, and relations. And then gender blind research, which ignores gender power relations. And often gender blind research can fall into the gender unequal category because they're not considering unintended consequences of the research process. So we want to avoid both gender unequal and gender blind research and move towards gender sensitive, specific, and transformative research. So gender sensitive and specific research both consider inequality generated by unequal gender norms, roles, and relations. The big difference is while gender sensitive research considers it and collects data on it, it doesn't do any action to address it, whereas gender specific research does that, takes remedial action to address it, but at the same time does not change underlying gender power relations. And that's where gender transformative research comes in. So gender transformative research actually seeks to challenge and change existing gender power relations. So on the left here, you'll see a number of activities at what I call a pyramid. At the bottom, we have do no gender harm. That's basically do not perpetuate existing gender inequities. And then all gender sensitive, specific, and transformative research should be doing the activities at the bottom of the pyramid here. So the base, these are the foundational activities. They include disaggregating data by sex and other social stratifiers using gender analysis frameworks. You can use a gender analysis matrix, including intersectional gender sensitive questions into your research and interventions. considering how considering how you're incorporating gender into your data collection processes, and then also thinking about it in terms of analysis. And as you see, as you go up the pyramid, we have other activities like stakeholder engagement that's really important, whether you're incorporating gender into your actual aims and objectives of your research. And at the very top here, this is gender transformative research, where you're looking using specific methods to actually address underlying gender power relations. I just want to walk us through just a couple of these, just to give us a very quick snapshot of what incorporating gender into human resources for health research might look like. Let's start with data disaggregation. So sex disaggregated data is very important for gender analysis, but it is not gender analysis. It's used as a trigger for further understanding and exploration. We say sex disaggregated analysis, but you can also do gender analysis in sex specific studies. So with just female or women nurses, for example, or women physicians. But then what you'd want to do is use data disaggregated by other social stratifiers like age and race, for example. And data disaggregation is critical as aggregated data sets mask differences. So what about gender analysis frameworks? Well, these help us to further organize our thinking, frame our studies and questions, and within our data collection and analysis. There are multiple frameworks that you can use. They both classify interventions and can be used to guide research and interventions. Here is a common one, the Gender Equality Continuum tool. This is very good for those using interventions, looking at from gender exploitative, accommodative, and transformative. So again, we have gender blind research and then gender aware. Gender exploitative research actually reinforces or takes advantage of gender inequalities and stereotypes to get its message across. So there you could be doing gender harm. Gender accommodative research or interventions works around existing differences and inequalities. And again, transformative research and interventions seeks to challenge and change those. This is the WHO Gender Assessment Scale, which we used in the model previously that looks at the gender sensitive and specific and transformative research and interventions. And then the other form of frameworks are ones that we can use to help interrogate our data and make sure that we're incorporating a gender lens into our work. These help inform and develop our gender aware research and facilitate data collection on gender power relations and the ways in which gender power relations manifest to create inequities. Here are our two very common ones. The one on the left is the one from the paper I mentioned earlier. The one on the right, the JPIGO framework, is from their toolkit on incorporating gender analysis into health systems. And both frameworks are very similar, but what they're doing is looking at the different ways that gender power relations manifest as inequities in access to resources, in roles and practices, and norms and rules and decision-making. I wanted to end very briefly, just touching upon gender transformative research and interventions. This is what we all aim and aspire to be. Of course, not all research and interventions can be this, but it's important to know what this entails. So what is a gender transformative approach? Well, this approach looks to create opportunities to actively challenge gender norms, promote positions of social and political influence for women or other groups, and really to address power inequities. Really, these approaches create enabling environments for transformation by going beyond just including individuals as participants. So methods to transform gender power relations include interactive awareness building, educational activities, create space for community engagement and debate, facilitating discussion on gender norms, and are participatory, centering power and challenging both the implementers to reflect on and redress power balances. And these often actively involve participants in the process. So with that, I'm going to leave you with some additional resources and hand it back to Morena to introduce our excellent panel today, who are going to be talking about how they themselves have integrated gender and intersectionality in their human resources for health research. Thank you.
Great, thank you so much, Rosemary. So the next part of our discussion is going to be a panel discussion, and we have some great panelists with us, and I'm going to go ahead and introduce them. First of all, we have Dr. Rupa Dutt. Rupa is a passionate advocate for gender equality in global health and the leading voice in the movement to correct gender imbalance in global health leadership. Rupa is particularly committed to addressing issues of power, privilege, and intersectionality that keep many women from global health leadership roles to opening up spaces for the voices of these women to be heard. Determined to build a movement to transform women's leadership opportunities in health, Dr. Dutt co-founded Women in Global Health in 2015. Today, Women in Global Health has more than 20,000 members in more than 90 countries and continues to grow. Rupa, you're very welcome. Next, we have Dr. Zara Zainali. She's a medical doctor from Iran. Zara obtained her MPH from Johns Hopkins School of Public Health. She's currently a fellow with the Rockefeller Foundation Boston University 3D Commission on Health Determinants, Data and Decision Making, and a researcher with Global Health 50/50. Her work is focused on health policy, systems, and gender and intersectionality. We also have with us Aisha Idris. Ms. Aisha Idris is a pharmacist, lecturer, and multidisciplinary researcher working for the College of Medicine and Allied Health Sciences, University of Sierra Leone. With over 10 years of cumulative teaching experience, she also recently completed her research fellowship with the African Research Excellence Fund, aiming at supporting early career researchers through leadership programs and capacity development. We also have with us Varo Sertor. Varo is a nurse with an MPH and the country gender focus point for JPIGO. In her role as gender focus point, she co-leads the gender assessment in registered midwife and medical laboratory technician pre-service programs in Liberia. She also served as lead facilitator for the GIZ Health Facility Leadership Development Program in Liberia, with specific focus on improving leadership and management skills in female management. Panelists, you're very welcome. And I'm going to go ahead and start with a question to all of you, and I'll go through each person one by one. And the question is, how did you incorporate gender into your research or interventions? And I'll start with you, Zara.
Hello, everybody, and good day. Thank you, Manya, for your introduction and your question. I'm very glad to be speaking about my experience conducting research with a gender focus here today, particularly on the topic of human resources for health. I think given the data and information that Wenya started her presentation with, it's very obvious that gender and power relations among different genders play a very strong role in how the health workforce is planned and is functioning. And it's really important to be able to implement that aspect sort of by default in any of the research that we do on health workforce issues. I want to bring in an example from one of the studies that I recently did on the leadership experiences of healthcare managers in coastal Kenya in the context of a recent decentralization that happened there. The way that I and the rest of the researchers incorporated gender from the very beginning in the study was being aware of the role of gender not only in the day-to-day career of these healthcare managers in Kenya, but also the nuanced experience that it creates in terms of their progression towards leadership positions. So we designed the study with that in mind. We approached the data collection with that in mind. When it was a qualitative study, so when we were selecting the participants in the study, we tried to act in a non-gender blind manner, so at least be gender sensitive, gender specific, and try to select participants that represent different genders. And when it comes to data analysis and coming up with the recommendations from our research, it's also really important to be open to emerging themes that are sort of affected by the gender of the study participants, and have an eye out to kind of get those themes extracted out of the interviews that we did, and try to, in the context of doing interviews, be able to ask leading questions, if that's the style of the study, to bring out even more details. I think with the recommendations and with the culmination of the paper, it's also really important to bring out that theme and focus on the fact that we already know that there are these discrepancies. So we're trying to gather more data on it, but also bring out more recommendations and practical steps to move these, not only research, but also the interventions that are based on the research towards a gender transformative approach. I'll stop here now. Thank you.
That's great. Can I actually stay with you just for a few more minutes and ask you to go beyond gender and into intersectionality a little bit more? What would you recommend we should do to go beyond gender in our research?
Absolutely. Thank you for that excellent question. So in a very quick review, intersectionality is this framework and idea that disadvantages are not happening in silos and in vacuums. So there are various aspects of each individual's identity and social location that are constantly interacting with each other in dynamic ways and within larger structures of power and other systems and structures that we're living in. So it's really important to doing the least and being gender sensitive, but then also having an eye out on what is at the moment intersecting with gender and creating different experiences of privilege and disadvantage, and being able to capture and record these in the context of research is really powerful, because as Rosemary mentioned, we can't really change anything unless we have actual data on it and we're able to measure it. So what I would really recommend is being able to operationalize intersectionality in the research that we do in health systems, and more specifically in health workforce research. And there are so many resources out there that explain how to operationalize intersectionality based on your methods, if it's mixed method, if it's quantitative or qualitative, and I won't go into that detail. But I think as a first step, it's important to do the preparation and background study, get involved with the community that you're trying to study, and therefore be able to understand what is happening beyond gender or alongside gender that's affecting the experiences that we're trying to study. So just a short example is when Mwanya mentioned that there's only 25% of women who are health leaders. If we take an intersectional look at it, we can see that there's only 5% who are women from low and middle income countries. So if we did not take that extra step of, further disaggregating our data, we wouldn't really be able to see this disadvantage that is affecting people from a certain geography or background to this extent. So I think this would be really powerful to try to move beyond that and see what are the social identities such as age, income, education in health workforce. Cadre is incredibly important, professional cadre. Trying to capture those and analyze that, I think would be really helpful.
Thanks, Zara. You brought out some really interesting and important points. I particularly like the point about data disaggregation, and also mentioning that we can't improve what we're doing to measure, which is also very important. Aisha, can I come to you next? And I also have two questions for you. The first is the same that I asked Zara earlier. How did you incorporate gender into your research or intervention, Aisha? I think you're still muted, Aisha. We can't hear you.
I'm sorry. Thank you very much. Hello, everybody. So for us, we're involved in a project that was part of a bigger project that aimed to identify how community health workers can be better supported to play effective role and long-term role as part of a broader health care system in fragile contexts. So what we did, we used the photo voice method to, one, understand the life that CHWs were going through, to understand the life particularly in Sierra Leone. And also we wanted to illustrate the challenges and supports that they had as CHWs, and also the experiences. We wanted them to illustrate their experiences in terms of their coping mechanisms that they were using as CHWs. So in terms of the gender lens, how we incorporated, we did it from the very beginning. We're aware of it in terms of recruitment, through data collection and data analysis. So during recruitment, we ensured that, because we used two study districts, one was a riverine area and the other one was a non-riverine area. So we ensured that we had equal number of male and female participants in both areas. And also down to the analysis, because what they did, they had their photos, and that's what we use for the project. So they took their photos and came back. So during the analysis process, so a gender lens, we use the gender lens throughout that process. So, and because of that, that's really shaped the health experiences and access to the services that these community health workers were having or going through or being experiences. That really emerged strongly as key themes. So, and one of the things that came out, that CHWs demonstrated how they negotiated gender norms within the communities that they were operating in. So for example, and I'm just going to share a few slides just to speak to what I'm saying, to get some context. Sorry. Yeah. So, for example, some of these photos that were discussed highlighted some of the challenges that these community health workers face within their communities. For example, the riverine area that I mentioned, they had like stagnant water, that insects can breathe into, like mosquitoes, and that was bad for the health. But what they wanted us to understand was that children can play in this area, and these were also areas for work for adults as well. So these were challenges that were being faced in the community. They also brought out a lot of other gender challenges. Another example was an outdoor toilet, which is very common in these areas as well. And most of them wouldn't have doors. And these, for example, are risk for girls because they don't have any privacy, and they would have other risks. So multiple challenges in addition to that were faced with women as well during pregnancy or labor, for example, in terms of access. So this is one of the study areas, which is the riverine area. And obviously to get to health facilities, to access those facilities, you would have to cross the river, because most of the time the roads are really very bad and non-motorable. And even with motorbikes, most of the time they would deny access to, to take these pregnant women to these facilities, because they might raise the fare, or they're fearful of the road as well, so they wouldn't want to use it. So most of the time they would have to cross these, get across to the facilities through these rivers, and they would have boats and paddles, which canoes, which, most of the time are broken. So all these cause challenges in which sometimes they would delay pregnant women from reaching health facilities in time, which again may lead to infant and maternal mortality. So in addition, as part of the coping strategies that they use to come up with, CHWs also would negotiate gender norms. They negotiated gender norms. For example, they would have teenage pregnancy, so they have girls, after they have their baby, they would negotiate with their parents to send them back to school. And they also mentioned having a fund, which was launched. So what this fund did, it was the Child Access to Education Fund. So these would give teenagers a second chance after they deliver the babies, financial support and other support so that they would get to these facilities. So these are some of the ways we sort of incorporated this gender into our research. So ensure that these come out mostly during these analyses, that we try to get these nuances together and bring their voices together. Thank you very much. I'll stop there for now.
Thank you so much, Aisha. And I like the picture that you've shown. It's true that the picture really does say 1,000 words. It's great to illustrate your point through these images. I have one more question for you. And the question is, how would you move from a project being gender sensitive to gender transformative?
Thank you very much. I think this is a really great question. And for me, it sort of relates to how you would change the underlying power dynamics. So having a focus on community sensitization is great if you can do it. But I feel like it's more important, especially when you're working at community level. So you would want to empower participants to use participatory methods like we did, for example. So that would enable them, we believe, enable them to collect the data, and also they will own, their data as well. So that usually will build their capacity and hold people to account. So it also really empowers them to be aware of what gender or power dynamics are and the different dynamics there are, and also to try to address them. So in getting them involved in all of these, they naturally would understand and try to address most of these things, which came out very strongly in our research. So for example, again, we had some power dynamics, I think it was Rosemary that mentioned, again, with male, female, having those together in terms of one being outweighing the other, you're having them all in the same environment. So we involved them, and it was, so to me, it's not really, for example, with women, because in our society, most of the time, women don't usually have the voices. So again, it's not really just having the space for them to speak, but also to allow them to feel confident to speak and to be listened to. So once they're aware of that, that really helps. Also, we could also involve men and female community health workers in priority settings and policy making. So for example, during our dissemination, we did things like that, which really was very powerful. And the policymakers were there. We had CHWs to present their work. And so it was like a hands-on thing, they heard from them. And all of these projects was geared towards, because a new policy was being developed. So it really helped towards that. And a lot of things were incorporated in the end. So, and again, allowing them beyond tokenistic involvement, to co-create and strategies right from the start is really very important. So I believe participatory approaches can help. Here, solutions are co-designed and co-created. So really, in conclusion, understanding that men, women, CHWs, nurses are not a homogeneous group. Understanding the unique circumstances or nuances will not only, we would want the participatory method research in a way that it would help, it would be really, really helpful to bring all these things out. Thank you very much.
Thank you so much, Aisha. You're really taking us to the front line and putting all of the research into practice. It's great. It's really great to hear from you. Varo, can I move on to you next and ask you how you incorporated gender into your research and interventions? Thanks.
Thank you so much. Like we all know, and you have said it, that with the health workforce, we have more females than males in the health workforce in most of our countries. So that is not even different from Liberia. According to our health workforce census, women make up 45% of the health workforce here. But notwithstanding, when it comes to representation in leadership and management, women, the participation of women is very low. Although I don't have the figure, but from the report, it shows that senior positions like directors for the 15 counties in Liberia, you only have 2 females who will be in that kind of position like that. So, and so many positions, some of the other positions, you don't have any representation of a female. So that shows that women representation at the leadership and management position are very low in Liberia, like other countries. So ours was an intervention. And based on this report, that was how we decided to do this intervention with GIZ, and they provided the funding. So in collaboration with the Liberian Nursing Midwifery Board, CHIPAICO, implemented this intervention in 5 of our counties here in Liberia with officer in charge. And officer in charge are people who manage the health facilities. They are lower managers. So what we decided to do was to see how we can develop that program to strengthen and expand leadership management and the capacity, as well as to improve the health sectors and build a career ladder for females managers. So we work along with the county health teams to recruit participants for our study. So we recruited 15 participants from each of the counties. 5 was a male and then 10 female. So to be part of the study, you have to be working in the county, you have to be an OIC. And once you are a female, you have a chance of entering the study. So in total, we had 50 females and 25 males in our intervention. So we did a mixed method. We did a blended approach. We did training, in-person training for each of the 15 participants in different 5 cohorts. So we had 3 rounds of training for each of those participants. So both males and females, 15 of them sat in one of the training. We also provided individual coaching sections for each of those participants. So it was one-on-one. We had a coach and then a participant, and then they had a project to work on in the facility. That project was you have to use your skills and the capacity that you learned from the program to implement a project within your facility. So we supported the team, both male and females. Now, how did we do with the gender aspect? Knowing that women participation was very low, and from the data it also showed that. So we decided to organize this management cycle meeting. And the management cycle meeting, it was only 4 participants, female participants. They were the ones. So that was the extra support that we provided to the team there. And during those sections, we talked about different things that happen with women at the workplace, especially women in leadership. And based on that, participants who are OICs and their leaders, they were able to share their experiences on how they too have been faced with gender norms that stop them or prevent them from doing their work. And then we all would discuss it, and then we come up with solutions or suggestions. And at the end of each training or workshop or the meeting, we will come up with one action that the female participant is going to go back with, and then she will be able to implement that at her facility. And then the next meeting, she will be able to come back and report on how it went. And that one action had to be something gender related. So at the end of the intervention, it was a 10 months intervention. At the end of the intervention, each of the participants, including the males and the females, did a project that was presented to their different county health teams and different policy makers to see how, if you support these ones, they can become good managers, even if they don't have, if they have limited resources. So those females were able to present their projects to their managers during the project. However, there were some challenges that we also faced. Knowing that all over the world today, we have people who, when it comes to the office housework, because of the practice, the office housework is always being done by a female, whether you are a manager or not. For example, if they have a data to enter, they will rather, can you please go and get us food or so, and then while we do the work. So they see you as that female in that place who's doing the office housework. So the challenge was, because of that practice, how to engage those women so that they see themselves as manager, and they should be on par with their counterpart instead of doing the office housework. How could they use the strategic no and then do more positive things? To get them to do this, that was one of the biggest challenges we had because of the practice, the common practice found around here in Liberia. However, we were able to succeed with most of our work, and those women were able to move from one stage to the other. At the end of the day, of our 50 female participants, at least we have like 5 of them who were being promoted to another level in another managerial skills, higher managerial level within their different counties. Some of them were even given scholarship to go and study so that they can come back and then play a more important role or take on a more important, higher managerial role within the health system in Liberia. So that was how we incorporated gender into our work. Thank you.
Thank you so much. This is a great success story. It's really exciting to hear about what you're doing. And I also like how you've brought out the importance of cultural norms. It really cannot be underestimated. So I have another question for you. Now that you've done all this fantastic work, how would you sustain the gains made in this transformative research?
Well, I can always say that the whole meat of the program was this management cycle, because it was like first in the kind in Liberia. So what we did, we organized network with those females participants who also incorporated other females into the network. So we created a WhatsApp group, we created Messenger group, so that they keep connected even after the project was implemented. And we ourselves, as facilitators or coaches, got involved. We are also part of that network, so that we keep the ball rolling and keep on providing support. Although the project is over, we keep on providing support for those females so that they can continue to excel in their practice.
Great, thank you. Thank you once again for your contribution.
And then to ensure that policy-wise, we also worked with the Ministry of Health and also our different partners to see how they can look into the policy and see how they can provide certain slots that should be managed by a female manager, even if that was maybe a male who had been in that position, because there are some positions in Liberia, although it's not policy, but I mean, it's a no-go zone for female. They are always male. So we also still working with policymakers to see how they can ensure that they leave a space for women so that they can be able to excel in managerial position.
Great, thank you. Again, great examples of putting research into practice. We have about 10 minutes of this particular section left, and after this, I'm going to go and hand over back to Rosemary for a bit of audience Q&A. And I just note that we don't actually have Rupa with us, unfortunately. She wasn't able to join us today, but we look forward to speaking to her at the next opportunity. So let me circle back with another few questions within the last 10 minutes. Zara, I'll come back to you. And can you tell us, is there anything you'd have done differently to make your research more gender transformative? Zara?
Thank you for this excellent question. Going back to the study that I briefly presented, the healthcare managers' experiences of career progression in coastal Kenya. So as I said, we did what we could in terms of data collection and data analysis with both a gender lens and an intersectional lens. And I think if we were able to do more, what could have made the study more participatory and more gender transformative would have been to kind of involve the people who participated in the study in the final steps while, you know, doing the final touches on the recommendations. And then it's sort of an extra step beyond the research, but if we would have been able to kind of involve them in reflecting these findings back to the health system of their counties and of the cities that they were working in order to present the challenges that men and women were facing in their career progression, but also, you know, with an intersectional lens, depending on their cadre, their background, that would have been taking the extra step and going the extra mile to be able to actually implement a better alternative to what was happening. But we kind of, as it is with a lot of the research projects, we're not able to do that. So we just, the best that we could do is to kind of implement these findings in terms of recommendations for different audiences and policymakers to, you know, open their eyes to the realities that are happening in terms of the power dynamics and the norms that are at play in the health workforce. So that in the future, the design can be more gender transformative.
Great, thank you. Thank you so much, Zara. Varo, I'm going to come back to you next, and I wonder if you can tell us a little bit more about the challenges you encountered when you were integrating gender in your research or in your project.
So as I said earlier on, thank you very much for. So the challenges that we encounter was moving from the common practice that we have today. Those practices does not focus on how gender impact inequalities. And one of what we can say is looking at how women should behave when they are in leadership. You know, if a male is in a managerial position, people expect him to be tough, and he has to be that guy whose his yes is yes and his no is no. But with a female, they expect it to be the other way around. So that was our main challenge. Getting those females to know that you can be soft, but you can be assertive was one of the greatest challenges that we had in our research.
Great, thank you. This is, I'm sure, something that many of us can relate to, and it's certainly something we haven't all found the answer to. Aisha, I'm gonna come back to you, and I wonder if you can give us advice. This is a tough one. What advice would you give health systems researchers that want to incorporate gender into their research? Over to you, Aisha.
Thank you very much. Well, I'll start by saying, don't be scared. I think gender is often conceptualized as abstract, but actually there are concrete actions that you can take to think about gender throughout the life cycle of a project. And often this comes down to asking questions. For example, does this person have autonomy to speak? Are the methods they use inappropriate? What power dynamics are at play? You know, so asking these questions help as well. And also looking at frameworks for inspiration. For example, Rosemary, I think, shared their framework that they use, things like that. And also looking at research that has taken an explicit gender focus, which there are many examples in the literature. So you can also take simple steps to consider gender and power imbalances throughout every stage. For example, recruitment stage, data analysis, and data collection and data analysis of a project. And I would also say, in addition, don't be afraid if you make a mistake or you are too far in the journey and you think, oh, I should have thought about gender before. Although ideally you would really want to think about it in the beginning, but always know that it's not too late to start thinking about it during the process or the time of the project. So you can always incorporate it during that time that you at least are aware, or it comes to your notice that you have forgotten about it. And finally, I would say be reflexive. So keep a reflexivity diary. So, and this, again, you would use during the analysis process, which you maybe think about the people as individuals, your participants as individuals, and that their individual experiences that come together usually shape the story that you're trying to tell. So that's what I would say. Thank you very much.
Great. On that note, I think it's been a great panel. Sending a virtual round of applause to all of our panelists, and thank you so much. Thank you so much for the conversation and for joining us today. Let's open up to some audience Q&As, and I'd encourage the audience to use the online app to go ahead and ask questions to our panelists. We're here for another few minutes. It's been a great discussion, and let's continue to have this conversation. So can I hand over to you, Rosemary, for you to moderate some audience Q&As. Over to you, Rosemary.
Sure, thanks so much, Mwanya. So please do type any questions that you have in the discussion forum, or there's the live Q&A, you can type them in there too. So while the audience is sort of thinking about questions to type, maybe I will ask Zara you a question. I'm curious, you talked a lot about, bringing in intersectionality to your work, and I was wondering if you could talk a bit more about what opportunities you see to advance that intersectional lens within, within human resources for health research, but also, bringing in gender as well.
Thank you for that question. So I think even this session is a great opportunity to prime everybody's minds on being able to see these nuances and take the next step into incorporating it into the different steps of their research, but also specifically on health workforce research. I think it's a very dynamic area of health systems research, and there's certainly a lot of different sort of variables that we can take into account and bring in the context of intersectionality to be able to study the nuances of the functions of health workforce. And I think this particular branch of health systems research is quite unique in terms of the vastness of how we can operationalize intersectionality and how many ways of interrogating these power dynamics and power dynamics and relations that are at play in the health workforce there are. I think being always mindful of this continuum that you started the session with, and trying to take a step further every time and incorporating as much of it to move towards gender transformative research and interventions would be a great step. But I would just urge everybody not to stop there and always ask what is intersecting with gender that I'm not studying or I'm not looking at. I think these are some of the opportunities that allows us to better understand health systems and health workforce issues.
Great, thanks so much, Sarah. So we do have some questions coming in from the audience, and I'm going to pose this one to you first, Varo, but then see if other panelists would like to contribute, because I think it's relevant for all of our work. So the issue really is around, buy-in, buy-in for gender. And the question is, how do we convince specifically male managers that a gender lens is a must in any health systems health research project? So how can we get that buy-in? I mean, not just from male managers, but from top level leadership.
Thank you very much. So one way we could do that is what I look at from the LTP Plus that we did. So having male managers come together and then discuss the issue and see how they can help, or they can help empower women working in leadership role. So if male managers are able to identify those inequalities or those equality issues that are found in the work setting, they can be able to buy in, and they can be able to transform their former roles and then see how they can make allowance for female managers. So getting them together is to discuss the issues and then come up with with common suggestions, I think is one of the ways that we can do. And with the LTP Plus, I think if I'm going to do it differently, that is why I'm going to incorporate both males together who are managers and see what they think about the issues.
Thank you. And Aisha, I wanted to see if you had any sort of thoughts and reflections about the issue of getting buy-in.
Yeah. It's really just reiterating what Yahu said. So similar to what she said, I believe that getting them, because with our work, it worked a lot. So in getting them involved. So not maybe you say at the very last stage, because to me, the more they understand the nuances, the things that play, the different dynamics, the better they are to at least find solutions or, incorporate women or female leaders. So I believe getting them involved is really key, very important, and allowing them to, within decision makings, or even if it's the work, the research itself, to understand how these things are coming up, allowing maybe again participants to explain things to them firsthand. So as long as any way we can get them to understand these things firsthand helps a lot, rather than just reading it and saying I've done this and all. So it's the involvement for me that would, help a lot.
Great, thank you. And Zara, do you have anything to add? I think buy-in is a really vital issue, and I think important in all our work. So any kind of tips and tricks we can get, all the better.
Thank you. I think the most important things have been already said. I just want to reiterate. I think, in terms of the management getting their buy-in, I think it's really important to be able to showcase how this issue, while it is really important for the quality of the work that human resources for health do, but also how it would make it easier for the management to see improvements in the performance and in the services that are provided to the community. I think being able to look at it from the point of view of the stakeholders that we're trying to engage and get their buy-in, it would be really crucial to get them on board in a sustainable manner to support this cause.
Great, thank you. So we talked a lot about how, it's really interesting to hear how each of you have integrated sort of a gender and intersectional gender lens into your work. I'm wondering where do you hope to see gender analysis, intersectionality, where do you hope to see it go within health systems research in the future? Where where can you hope that where can we move to? Maybe I'll start with you, Aisha, first with that question.
Okay, thank you very much. It is my hope that we get to the stage where there's equality. we all understand that, it is not a competition, if you understand what I mean, but that the collectiveness of our work, that each, like everybody would sort of bring their own strength into work, and we sort of, well, it will be difficult to forget, but there's limited thought of this gender, and again, a lot of cultural and other things come into play that really, work with this gender lens and segregation. So again, breaking through those barriers to help us all to understand that, working together, would yield a better and fruitful goal than just individually or segregated male and female. So it is my hope that, the work one day would get us to that stage where, it will be understood that yes, collectively we can do it, and it is not a competition. Thank you.
Great, thank you. And Varo, what are your thoughts on where do you hope to see this work go?
Yes, so everybody, thank you very much. Everybody want to see this work get to the stage where we work collectively. I look more forward to where we can be able to support each other, so that despite your background, despite the norms that you have, we all put all those aside and then we help each other. Most of the times when I think about this, I think about the gender equality tree, where you have people of different sizes, but then you have different support group supporting them so that everybody reach to the top. So there where I want us to reach, where we will have people supporting us despite of all the differences, so that we can be on that stage and then everybody can be able to produce or carry out their work in just a manner that people will be pleased.
Great, thank you so much. And Zara, how about you? Where do you hope to see it go?
Sure, thank you. I think the final goal of doing research is to be able to improve health systems and health outcomes. And I think what I want to see happen is, particularly with the health workforce issues, to be able to unpack a lot of realities of who is being left out of the decision making, and who is deprived of their voice and their opinion within the health workforce, and being able to bring all those voices and all those people together, regardless of whether they're man or woman, or if they're a midwife, community health worker, or a specialized doctor. I think ultimately the best case scenario would be to be able to use everybody's potential to the highest in the health workforce. And I think incorporating gender and intersectionality in the research that we do is a first step. It's a challenging path, but I think it's something that's completely doable in the near future.
Thank you. And my last question for all of you before I hand it back to Morena to close this out is I love the question that Morena asked Aisha, and I loved your response, Aisha, about what advice you would give. So I'm going to pose that question again. And Aisha, I don't know if you're going to be able to top your previous answer, but I'm going to give you a try. I might start with Varo so you can have a bit of think about how your answer. So Varo, what advice would you give health systems researchers and implementers who want to integrate a gender and intersectional lens into their work?
Okay, thank you very much. So we all know that gender is often neglected in the health system, but yet gender is not neutral within the health system. So for people who are doing research and want to incorporate gender into the research, for me, I think they should use a mixed approach. And that mixed approach will involve regulation, organization, and then the part about information approach. That is the participatory part that goes with gender transformation. So with the regulation is to look at policies, is to look at policy makers so that they can be able to make decisions properly that will kind of make gender to be part of the health system. And then the organizational approach is looking at tools and things that will highlight gender inequalities and then pinpointing those solutions to solutions to those issues that will be that will come about. Thirdly, when you talk about information or participatory, let it be both male and female, despite their background, coming together and see how they can work together to strengthen or to reduce the gender inequalities that have been found within the health workforce. So my three things is it should be a mixed method, it should be a regulatory approach, organizational approach, and the informational approach. I think with that, when you are doing your research, that will really help.
Thank you. And Zara, what advice would you give?
Honestly, it would be really difficult to top Baro's answer. I think she encompassed everything that's necessary to say. But I would just reiterate that I think just approaching our research with the frame of mind that we're trying to do good to the community would enable us to engage with the community that we're doing the research with much more, and that would automatically open a lot of doors that would enable us to adopt these more participatory approaches. I think just shifting this mindset from just publishing papers to actually implementing something based off of our research would be really helpful in terms of understanding these nuances that very easily get lost in data collection or even interviews. Thanks.
Thank you. And Aisha, I'm putting that question back to you. What other advice, additional advice would you give researchers and implementers who wanted to integrate gender? Oh, you're on mute, Aisha.
Muted.
I'm sorry. Okay, I'm sorry. So yes, so in addition to what I said earlier, I would just say try to treat your participants. I mean, forget that they're participants, and remember they're working. You're working together with them for a common good for everybody. So, and also try to let them understand that the work really you're doing, it's not, because sometimes they feel like it's for just the researchers' good, but then the minute they get it, the minute they understand that this is for a general good, so many things come out of it that maybe you might not even have thought of. So it gets you into a really good and better focus of the research. So just try and, find ways of doing those things. Be empathetic and, depending on the situation you're dealing with and where you find yourself. Thank you.
Thank you. And with that, I want to hand it back to Morena. Morena, we have about 1 minute and 20 minutes left, or 20 seconds left. So to please close us out.
Great. Thank you, Rosemary. Thank you for your contribution. And thank you once again to the panelists for a very, very rich discussion. I hope you've all enjoyed the session. Throughout the session, we've been able to better understand how gender and broader diversity affects the progression of human resources for health, and also how we've been given concrete examples and activities needed to move human resources for health research along a continuum towards gender transformative approaches. Thanks very much once again to everybody. I'm going to go ahead and close the session. Thanks, guys.
Thank you. Thank you.
Thank you.